Yes, you can start.
Okay, before we start, just to remind you to sign your attendance. Okay, last week we talked about Cluster Division 1, then today we're going to talk about Cluster Division 2 malocclusion. So, same thing, we go through etiology, then what's the features, and what's the treatment plan for the Cluster Division 2. So, the etiology, same thing, we divided into skeletal, and later we divided into dental factor. So, skeletal first is usually due to the reduced lower facial height. It means patient have a short facial height. If we look at the patient from the front, then we divide the face into three portions. So the first is the top, which is called the upper, then middle, and lower. So when you have the reduced lower facial height, it means you have the reduced vertical proportion from the nasal to the mantle. It means the lower facial height. Can you see my cursor? Black color?
Yes.
Okay. So you see this one is the upper from the forehead to the lesion. Then from lesion to this one, the nose, base of the nose. Then from the base of the nose to the menton. So this one is divided into three portions: top, middle, lower. So the lower facial height means from the base of the nose, then to this the mandible. So this class 2 division 2 features, usually patient have to reduce lower facial height. It means you have a short lower facial height. So they have the forward groove rotation, then the prominent chin and the increased overbite. So if the forward rotation means the jaw rotated forward, then have a very obvious what you call the angle of the mandible, then have a deep bite because the jaw rotated forward. Then compared to class 2 division 2, which is a backward rotation usually, then patient have an increased vertical height and they have what we call the increased FMPA, the mandibular pen. So dental factor, it can be have patient have crowding, then exacerbated by the retrocline upper incisor, causing the lower incisor to be trapped lingually. So imagine the upper incisor retrocline, then like is on the bottom right pictures. If the upper incisor retrocline, then we will push everything backward, then causing the crowding on the lower teeth also. So lower teeth will trap lingually, then can see the lower incisor crowding, which is very common for class 2 division 2. Then lack of the occlusal stop due to the increased inter-incisor angle lead to over-eruption of the lower incisor. So you see all the class 1 incisor, then the lower incisor occurred on the cingulate plateau of the upper incisor or the middle third of the upper incisor. That's why they have what we call the occlusal stop. Occlusal stop. I mean they are biting together, then they stop each other from erupting. So if this stop is not existing, like cluster division 2, they bypass each other, then the teeth will become over-erupted. So patient end up what we call the deep bite in the cluster division 2. So increase on the crown root angulation of the incisor due to the high lip line contribute to the increased inter-incisor angle. So inter-incisor angle, it just means the angle between the upper incisor and the lower incisor. So this is what we call the inter-incisor angle. If this incisor angle, the average should be about 134, then plus minus 6. And if this angle increase, like the cluster division 2, means that I don't have the occlusal stop. That's why the incisor can become over-erupted and the retrocline. So usually when the cluster division 2, when we treat the patient, then we try to correct this what we call the inter-incisor angle. So back to the class 1, which is about 134 plus minus 6. So soft tissue factor. So cluster division 2 patient usually have at least reduced lower facial height, contributes to the high lower lip line, causing the retroclination of the upper incisor. So imagine have the lower lip, which is quite high, then the covered upper incisor, then a strong muscle that push the upper incisor backward, causing the retroclination of the upper incisor. But this lateral incisor, they're having a short clinical crown length, so it can escape from the action of the lower lips, and therefore they are proclined and sometimes they're rotated mesiolabally. So imagine the lower lips, if they are not covering the lateral incisor, so the lateral incisor can move freely. So usually they're pushed by the lower lip and they are proclined forward. then compared to the upper central incisor, which is covered by the lower lip, then they will retrocline backward. So the bimaxillary reclamation is caused by the active muscular lips and irrespective of the skeletal pattern. So you have a strong lips muscle, then they'll push everything backward through the upper and lower incisor. So both can retrocline backward, then causing the crowding on the lower incisor and retroclination of the upper incisor. Occlusal features. So class 2 division 2, same thing. They're going to have an anchor classification, class 2, which means the molar relationship is class 2. So last lecture, we talked about class 2 molar relationship, means the mesial buccal cups of the upper 6 then occlude anterior or forward of the mesial buccal group of the lower 6s. That's how we classify the anchor molar relationship. So last lecture, there's someone asking about the class 2 division, the class 2 molar, half unit, quarter unit, full unit. It's based on how much forward, the mesial buccal cup, how much forward compared to the mesial buccal group on the lower 6. Then we divided all the cups, mesial buccal cups and distal buccal cups, into two units. So that's why you see how much forward, then how we divide it into the class 2, half unit, quarter unit, or full unit. So this class 2 division 2 malocclusion, this patient usually have retrocline upper central incisor. This one we talked about it just now. Because of the lower lip is covered upper incisor, that's why pushing everything backward, causing a retroclination of the upper incisor. Then procline and the mesiolabially rotated upper lateral incisor. Again, this one we mentioned before, due to the upper lateral incisor, the clinical crown is shorter compared to the central incisor. That's why the lip cannot cover the lateral incisor. That's why the lateral incisor is being pushed forward, or they can move forward freely, then causing the proclinations of the lateral incisor. Then deep bite or complete bite, or sometimes can be traumatic to the palatal mucosa. So imagine you have the deep bite, then sometimes can touch the palatal mucosa, then causing the traumatic bite. So if you check the patient, then you use a mouth mirror to see the palatal mucosa. Sometimes you see the indentations on the palatal mucosa. That's considered traumatic bite, even though they are not causing any stripping of the mucosa yet, but their potential will cause the trauma in the future. So if you see the indentations of this palatal mucosa, then you have to pay attention to this deep bite. So if possible, then usually we correct it early. Retroclination of the upper incisor, then stripping of the lower labial gingiva. So this one is due to the deep bite again. Imagine you have a deep bite, like this one on the top right pictures. So this one, the upper incisor, sometimes they deep bite, they are biting on the labial mucosa of the lower incisor. If they're long term, they can strip the lower incisor gingiva. So you pay attention to this deep bite. Sometimes it can be dangerous. Then if you correct it early, then everything becomes reversible. If you correct it too late, then it causes damage too much, then sometimes it becomes irreversible. Then patient can have prolonged or going to have permanent gingival resections, then it causes sensitivity or sometimes even the loss of this lower incisor. Lingual crossbite or scissor bite of the first and second premolar due to relative position of the width of the arch. So imagine if you push upper incisor backward and you squeeze the you squeeze the premolar buccally, then causing what we call the scissor bite. Because you're pushing the upper incisor backward, it's causing what we call the whitening of the width of the premolar. So everything you go backward, they squeeze the premolar sideways. So it's causing what we call the scissor bite on the premolar. So this one, if you look carefully from top or occlusally, they can see class 2 division 2 patient usually have a square arch. Means this upper incisor being pushed backward, then causing the premolar move sideways. Then they have what we call a square arch. Okay, so we know all the features: skeletal, dental, soft tissue. Then now we come for the treatment planning for the class division 2. So class 2 division 2, they're quite similar to class 2 division 1, but except there are certain features you have to pay attention. So at class 2 division 2, like we mentioned before, they have an increased interincisor angulation. So this inter-incisor angulation average is about 125 to 135. So we usually aim for this perfect angulation when treating this cluster division 2. So this is what we call the increase in the incisor angle. So you can see this angle between the upper incisor and lower incisor is more than 135. That's why we're going to have an occlusal stop. Occlusal stop, which means the lower incisor is biting on the upper incisor, usually on the sigmoid plateau, which is a middle third of the palatal surface. So that's how we aim for. And from the left to the right, you see the inter-incisor angle is increasing. And back to, reduce back to 125 to 135, which is called the normal. So how are we going to do this? So imagine this upper incisor is retrocline. The lower incisor sometimes have been retrocline also. What we're going to do, we're going to procline upper and lower incisor together. We push the upper incisor forward, then the lower incisor forward. That's how we're going to reduce the inter-incisor angle. So if you have this perfect inter-incisor angle, which is 125 to 135, then the incisor should bite on the cingulum plateau, lower incisor bite on the upper incisor cingulum plateau, which is 1/3, and which should be stable. This one we have our occlusal stop. Okay, so how are we going to reduce the inter-incisor angle? So inter-incisor angle can be reduced by the torquing of the upper or the lower incisor root palatal palatally or lingually. So I'm not sure you know what is torquing. Torquing, it means you are rotating the root backward or forward. So imagine this is a picture. See the root, you can move it forward and backward. That's how we change to what we call the torque of the upper incisor or the lower incisor. So when you're talking about torquing of the upper incisor root, it means we can move the upper incisor root forward labially or backward palatally. That's how we change the incisor angle. So proclination of the lower labial segment, same thing. We are changing the labial segment. It means you push the push the lower crown or the incisor forward. Then by doing that, then you change the torque of the root also. So basically, just pushing everything forward. That's how you reduce the inter-incisor angle. So proclination of the upper limb and the functional appliance to correct the resultant overjet. But imagine, if you push the upper incisor forward or you torque the root backward, by doing that, you push the upper incisor forward, you increase the overjet. And later, if necessary, then maybe you use the functional to push the upper incisor backward again. That's how we do the cluster division 2. What it means is you convert the cluster division 2 to the cluster division 1 first by pushing the upper incisor forward. Then you have an increased overjet. Then you reduce the overjet using the functional or fixed appliance later. So it can be a combination, the last one combination of all the above methods. So you can see these bottom right pictures. So this one is a typical cluster division 2, upper incisor lean backward. That this patient unfortunately have a premolar taken out. So we use the fixed appliance, then torque the root back. Torque the root back, and the upper incisor root will move palatally. Then the crown will move labially. By doing that, we torque the root backward. See the bottom left, the picture shows what the action is. Using the fixed appliance, torque the root back, then the crown forward. That's how we correct the inter-incisor angle. So reduction of the overbite. Just now we're talking about this, how we reduce the inter-incisor angle by pushing the upper incisor and lower incisor forward. Now we talk about how we're going to deal with the deep bite. The deep bite usually have to do some intrusion of the upper and lower incisor. But this usually you need what we call the fixed braces to do that. So through intrusion, using the fixed appliances and the headgear by the risk of the root resorption. So imagine if you push the root or intrude the root against the bone, then a lot of time they cause what we call the root resorption. So with two objects bang into each other, then either one will give away. So in this case, you see the bottom right pictures. Compared to A and B, the root is longer. Compared to B, the root is resorped. Sorry. So you see the picture on the A, the root is quite long before the treatment. Then after treatment, you see the root is resolved or it becomes shortening. So this is due to the high force. If it impacts the root against the bone, then usually the root will resolve. The heavy force you apply, the faster treatment you're going to do, then the more resorption is going to cause. So these braces or the fixed braces or whatever headgear, they apply the force to the incisor. So inevitably, then this one will cause what we call the root resorption. So whether they're more or less, it depends how much the force they put in and how fast they do the treatment. And of course, it depends on the patient, their own the root. Sometimes if the root is already too short, then if you're shorting too much, then the root, the tube will become weakened. Then increase the anchor unit by use of the bypass arch, improve the true intrusion of the incisor. So you see this one is the bypass arch. It means the wire we divided into two. You can see the bottom, the middle pictures. You see the wires, there are two portions. This one the first wire engaged on all the posteriority. Then they have a second wire which is bypass the others. Then this wire cause you're going to do what we call the intrusion. So if you let go this wire will push everything down. So you have to lift this wire up and engage on the lower incisor. By doing that, they will cause what we call the intrusion of the lower incisor. Of course, sometimes you can use what we call the headgear, using the vertical pull or high pull, and pushing all the incisor upward. That's how we intrude the incisor. But you have to be careful. Like I say, this one, be careful. If you use high force, it causes more resorption. So usually we avoid what we call the gentle force. You want to come to this intrusion. So relative intrusion, it means they are not the true intrusion. Because now this one, the first method is true intrusion. It means pushing everything upward. Intrude the upper incisor into the bone. This one I call it true intrusion. Relative intrusion, it means they are not really the true intrusion. It's by causing, using the over-eruption of the molar, then it causes what we call the increased vertical height, and it causes the reduction of the oval bite. So using the anterior bite plane, reducing the buccal occlusion around the lower incisor, lower molar to erupt. So imagine if you put the occlusal bite plane, so the patient every time they bite, the lower incisor might occlude on this palatal bite plane, then it causing the separation of the molar. So if you leave it long enough, this molar will erupt further, then they come together again. So by doing that, you increase what we call the vertical height, and at the same time, you open the bite. But this one is not causing what we call the true intrusion. You are not pushing or intrude the upper incisor, but merely causing the over-eruption of the molar. That's why I call it relative intrusion. It's not true intrusion, but you're pulling the molar out or extrude the molar, then that's how you are causing what we call the reduction of the overbite. They give you the false impression they are intrude the upper and lower incisor, but in fact you are extrude the molar rather than intrude the incisor. But this method only can use in the growing patient. So if the adult patient, then this method is not going to work because everything is already fixed. But growing patient, yeah, this can work. Then it causes the upper and lower molar over-erupt, then it causes a reduction of the overbite. So eruption of the molars and the spontaneous proclination of the lower incisor with anterior bite plane. So you look at this picture again, this picture. If the patient keep biting on the occlusal bite plane, then sometimes it causes a proclination of the lower incisor. It means they'll push the lower incisor forward. Again, okay, this one bottom right picture, it just show what I say just now. It's over eruption of the molar, then hopefully can increase the vertical height. Same thing, this one how we reduce the overbite by causing the over eruption of the molars. Okay, extrusion. Only extrusion of the molar to correct the deep bite. Same thing, this is similar to this relative intrusion. Extrusion is mean the molar extrusion. Intrusion mean the incisor intrusion. Okay, so advantages in reduced vertical skeletal proportion like cluster division 1, we say just now they have a forward rotation. Forward rotation means they have the reduced overbite and the reduced vertical facial height. So by rotating the mandible backward or extrude the molar, like the top right pictures, you can see if you're causing this over eruption or the extrude the molar, then this mandible will rotate backward. So when the mandible rotate backward, then it will cause an increase of vertical height. So if the patient have a short clinical facial height, then it's a good thing if you can extrude the molar and increase the vertical height, which will make the facial proportion better. And of course, the last one, you can do surgery when the patient have a deep or severe reduced vertical height. So sometimes you can extrude the whole maxilla. Then by doing that, then you can rotate the mandible backward, then causing increased vertical height. So this one only can use for the severe vertical reduction and adult patient, and of course with the deep bite. So space for relieving crowding by extraction or distalization. So this one you are really careful. If you have too much of space, you retrocline the upper and lower incisor, you're going to cause the deepening of the bite further. So usually for class 2 division 2, when you come to mild crowding, not too much of crowding, you try not to do any extraction. Like say we need to push the upper and lower incisor forward by reducing the lower and upper inner incisor angle, which will cause the stabilization of the result. So they avoid lingual movement of the lower incisor. So if you push the lower incisor backward or retrocline the upper lower incisor backward, I say you're worsening of the deep bite. You make the deep bite even worse. Then space closure more difficult and reduce vertical skeletal proportion. So if you have an increased vertical proportion compared to have this reduced vertical skeletal proportion, then space closure can be more difficult and a short vertical height compared to the have increased vertical height. So if you see the patient have an increased Frankfurt mandibular angle compared to the reduced Frankfurt mandibular angle, then usually the increased Frankfurt mandibular angle means a height, vertical height. The space closure will be easier compared to the short clinical vertical height, which space closure can be difficult. Proclination of the lower labor segment, caution to avoid gingival recession. But so this one, same thing, because the treatment for class 2 division 2, we procline upper and lower incisor, then you have to be careful. Sometimes if a procline or pushing the lower incisor forward too much, it might push the incisor out from the bone, then causing what we call the gingival recession. Because the teeth have to be inside the bone, then in order to have the healthy gum and periodontal support. So if you push the incisor outside the bone, then it causes what we call the gingival recession. So you have to be careful. So functional appliances can be used in the class 2 skeletal pattern with relatively well-aligned lower arch. So if they have the well-aligned upper and lower arch, then they just have the upper incisor sticking out, then you can use what we call a functional to reduce the overjet. This only can be done when you correct the upper and lower incisor angle. It means you're pushing the upper incisor forward, then by increase the overjet, then you can use a functional appliance to push the upper incisor backward again. So to conclude, so the first thing you have to identify the etiology. You see what is causing the class 2 division 1 and class 2 division 2 before you start treating the patient. So you have to diagnose the case carefully, whether it's a lip, skeletal, dental is causing this malocclusion. Then you treat it accordingly. So after you have diagnosed the case, you need to plan. After the plan, then you execute the plan accordingly. So if the skeletal pattern and the growth is variable, then growth modification with functional appliance or headgear can be done. Functional appliance can use twin block, headgear, high pull, low pull. So it depends if you have a short mandible or you have a long maxilla. So if you're short mandible, then you use functional. You have a long maxilla, then you use headgear. So mild class 2, more cases with a class 1 skeletal pattern can be treated with the removable appliances. So if there are very simple cases, then with a mild crowding, then it can be treated with the removable appliance. But in cases with a severe crowding and proclination and require bodily movement, then it's best to treat with the fixed braces, plus or sometimes with or without the extraction. So if you come to severe crowding, we extract, and if you come to severe overjet, then you extract. But sometimes you just some more crowding, then you can do without extraction, like class 2 division 2. Orthodontic camouflage, useful alternative in absence of growth. So if the adult patient, then when it comes to class 2 division 1 and class 2 division 2, like I mentioned before, it's best to deal with the fixed braces. Then a lot of time we take out the teeth, whether the upper or lower. Sometimes it can be upper only, sometimes it can be lower. Depends on crowding, the severity of the overjet, and the defect. Severe skeletal or dental discrepancy in the adult is managed surgically. So if the severe cases, then if you want to change the skeletal pattern, it always best to deal with the surgical approach, means orthodontic surgery. Either we cut the upper jaw or we cut the lower jaw. Then we align the jaw back to a better proportion. Occlusion must have a soft tissue harmony to avoid relapse. So after you align all the teeth, the lower lip should cover the upper incisal, which is called the lip competency or the soft tissue harmony. This can avoid the relapse of the overjet. So after you correct this overjet and overbite, if the patient cannot bring the lip together, I mean they're not going to have the lip competency, then this is not going to be stable. So like I say, the teeth have to be in balance between all the muscle. The muscle involve the buccal, your buccal cheek, the lips, the tongue, and the last one is a ligament periodontium. So all this soft tissue must be in the balance in order to maintain or stabilize the result. So retention phase until growth is complete. So you have to put the retainer, or you have to ask the patient keep wearing this twin block until their growth stop or complete. But a lot of time, the retention is for lifetime. So if you read the current research, they recommend the retention is for lifetime. So even though you stop the retention after many, many years, the teeth is still going to move. So to be safe, we always advise the patient, if you want the teeth straight forever, then you have to wear this retainer forever and ever. So it can be quite frustrating to the patient. But if you tell the patient right from the beginning, patient can understand, then if you're not going to wear the retainer, then you're going to bear the consequences, which is the teeth is going to relapse or move slightly. So how much they're going to move, no one can tell you. Some move a bit more, some move a bit less. So if they move too much, unfortunately, the patient has to go back the second time, third time, fourth time for braces, which is wasting time, wasting money. So my personal advice, retention for life is the best for orthodontic treatment. So I think with that, we finish the class 2 division 2, which is quite short for today. Do you have any questions to ask me? Do you have any questions? If there are no question, maybe we'll go through the learning outcome again. Okay. Can someone tell me what is the etiology for class 2 division 2? What's the etiology?
Skeletal factors, dental factors, and soft tissue factors.
Okay, tell me a bit more about skeletal factor.
The jaw, the lower third of the face is shorter.
Okay, why is it shorter?
The jaw is more rotated forward.
Yeah, it's rotated forward. So if rotated forward, we call a shortening of the vertical height. So when you look at the rotation, can be divided into backward rotation or forward rotation. But you okay look at the forward rotation and backward rotation from the patient side, which is a profile view, then patient facing the left. So this, let me see. Okay, that's how we classify the rotation based on these skeletal profile pictures from the patient from patient right side. So when we're saying the backward rotation, it means they are rotated backward. Forward rotation, it means they're rotated forward. Based on this view, based on this view. It's not the other side. If you flip the picture, left and right, then you will confuse with the backward and forward rotation. So we are talking about forward rotation, always based on this view from the patient right side. Okay, very good. So your first factor to cause this malocclusion is a skeletal. Can someone tell me about the tender factor? Why is it have the class 2 division 2? Cause not the same person again. So we want to hear some people's voice. Let me see who is online. Can we have Aiman? Aiman Mohammed bin Zulkifli. How about Zainu Iman?
It's okay.
Okay. Tell me about the factor.
Interfactor.
Yeah. Why are you going to have the class 2 division 2 based on the tender factor? Why?
Because there is no occlusal stop.
Yeah, very good. There's no occlusal stop. Why no occlusal stop?
Because the incisor edge does not meet.
Yeah. Where the incisor edge will meet? For perfect class 1 incisor, where the incisor, lower incisor, where is it meet with the upper incisor?
At the back of the cingulum.
Yeah, it's 1/3. That's why we call it a stable occlusal stop. So without this stop, then everything will bypass and will causing the recognition of the upper and lower incisor. Okay, very good. Can someone tell me about the soft tissue? Soft tissue mean the lips, lip and all the muscle. Can we have Fatima? No, Fatima? Yeah. Fatima, can you tell me about this soft tissue?
Reduce the lower facial height.
This one is skeletal, reduce facial height skeletal. How about soft tissue? How the lips will cause the class 2 division 2?
Lower lip line is high.
Lower lip line is high. That's why they cover the upper incisor, then pushing the upper incisor backward. Very good. What else? Then what about the lateral incisor? How the lips will cause lateral incisor proclamation? How?
The lateral incisors has short crown length.
Yeah, they have short crown length. That's why the lip cannot reach the upper incisor, upper lateral incisor. That's why upper incisor can proclaim or can move forward by themselves. So upper incisor, central incisor covered by the lower lip. That's why it's called the retroclination of the upper incisor, which causes the cluster division 2. Classical features. Okay, very good. Then how about the occlusal features of this class 2 division 2? So maybe we ask, okay. Right, I can't see very well. Okay. How about Chen Jie-en?
Hello, doctor.
Okay. Tell me about the occlusal features of this class 2 division 2.
It's the retrocline of upper central incisor.
Say again?
Retrocline upper central incisor.
Upper retrocline incisor. Then how about lower incisor? Usually crowded because the upper incisor push forward backward, then they're causing the retroclination of lower incisor also. That's why the incisor usually crowded. Then how about the bite?
Deep complete overbite.
Deep complete overbite. Okay, why is it deep and complete overbite?
Due to trauma to the palatal mucosa.
It's the other way, because of the deep and complete overbite, then that's why causing the trauma or the stripping of the upper mucosa. So deep bite sometimes not causing the trauma, but most of the time, if there's a deep bite touching the upper palatal mucosa, there's a potential to cause a trauma. Very good. So how are you going to assess the patient? Okay, this one is based on the externals. You assess the patient's skeletal, then internal. You look at the dental, soft tissue, everything. Okay, then we come for the treatment planning. Okay, can someone tell me how you're going to treat this cluster tip 2? Then maybe we go to Ganjai. Ganjai is wrong? No?
Yes, doctor.
Okay. Tell me how you're going to treat this class 2 division 2.
Correct the incisor angle to between 125 degree to 135 degree.
Oh, very good. You memorize the value. Okay, how are you going to correct this upper and lower incisor angle or inter-incisor angle? How are you going to do that?
By tipping the incisor root.
Tipping is usually for the crown. When it comes to root, you say talking about the root. So you talk the root back, then by pushing or tipping the incisor crown forward, then that's how you're going to reduce the inter-incisor angle or increase the upper and lower incisor angle. So by doing that, then you create what we call the inter-incisor stop. And by doing that, hopefully the result will be stable. Okay, that's one how you correct the inter-incisor angle. Okay, how you going to correct the bite? Usually cluster division 2, you have deep bite. And how you going to correct the deep bite? So let's see. Okay, do we have a lucky person? Oh, Rihanna. That's a good name, Rihanna. Yeah, do we have Rihanna? Is Rihanna wrong?
Yes, doctor.
Okay, good, Rihanna. Tell me how you're going to settle this deep and traumatic bite for class 2 division 2. There are a few methods. So how are you going to reduce this deep bite? Oh, Rihanna is gone offline. I suspect maybe the mic is not working. Okay, let's have Putri. Putri, around?
Yes.
Yeah, Putri, can you tell me how to reduce this deep bite?
By through intrusion.
Okay, how are you going to get this through intrusion?
Using fixed appliance and headgear.
Yeah, headgear, fixed braces. Then what's the consequences or what's the side effect if you do this intrusion?
Can cause
Oh, Putri.
hello.
Yeah.
Can cause root resorption.
Yeah, root resorption. The higher force you go, the more resorption you're going to get. Okay, that's first method, through intrusion. Can someone tell me what's the second method? They call it relative intrusion. Relative intrusion. Maybe you can have a sim funging.
Yes, doctor.
Yeah. Sim, can you tell me how you're going to do this relative intrusion?
By placing an anterior bite plane.
Okay, how this anterior bite plane will work? So this anterior bite plane, you have the lower incisor biting on the upper occlusal bite plane. Then by separating the upper and lower molar, then they have a gap between the top and bottom teeth. Then hopefully this top and bottom teeth can over-erupt. And when they over-erupt touching each other, and means the molars, the back buccal surface, buccal occlusion, then that's how you reduce the overbite. By doing that, over-eruption of the molar, then they reduce what we call the deep bite. So they give you the false impression they intrude the incisor, but in fact, they are just bringing the upper molar and lower molar outward or extrude. Then it causes what we call relative intrusion. Okay, so what's the other extreme method when it comes to severe cases, skeletal severe cases, short case? Then what's the final method? Then we have Dunn-Carmen. Uncommon. Carmen is not around, so I think maybe she went for some errand. So maybe we can have Inkaen. So when it comes to severe cases, Cluster Division 2, Cluster Division 1, what is the final method? When all this doesn't work, all dental, fiber braces, it doesn't work, then what's the final method you can do?
Surgery.
Okay, very good. Surgery. So everything we do maybe it's not going to work. Then we still have the surgery will come in as a backup. So what's the disadvantage for this surgery? So surgery, of course, they are quite a drastic method. Then it will cost the cost. The cost of first thing if you do in private, it might cost you 40 to 50,000. And easily, if you go for double jaw, then of course, patient must suffer from the post-op complication, pain, discomfort, swelling, and sometimes bleeding. And of course, this surgery method, they have advantages also, which you can change the face totally. Then the thing you can do with surgery is more than orthodontic or braces only. For example, this patient have a 60mm overjet. Then maybe bracer can reduce it by doing extraction of premolar. You can reduce it to 7mm. Then surgery can reduce the overjet completely to 2mm. That's how much the surgery can do compared to braces only. Okay, I think we cover all the topics, and I think you're quite good. Okay. So if no problem, then no questions, then I will end this lecture. Do you have any questions? No? No questions?
No, doctor.
Okay, good. Then if no question, I'll end this lecture. Then I'll see you soon then. Yeah. Goodbye.
Thank you, doctor. Thank you, doctor. See you.
Thank you, doctor.